then I'll hand it off. Hi, I'm Shelley with the Bureau of EMS and Trauma System. We're going to record this work group meeting. If you're not familiar with Google Meet, if you hover your mouse around the bottom of the screen, some commands should pop up: the microphone on and off, the leave the meeting, hang up button, and then the video on and off button. And please be advised that this is being recorded. Anything you say, type into the chat, or that we can view on the webcam will become part of the recording. All right, I think we're all set. Dr. Rice?
Cool, thank you, Shelley. So Shelley's got the agenda, it looks like, up on the screen. So we have some minutes from the last meeting that was sent out as an attachment, or in the calendar invite as an attachment. So we can review those briefly. Shelley, I don't know if I need to officially have the minutes voted on for this work group meeting or not really.
I'd say not necessarily, just if you see any obvious errors. It's really a vague minute.
Yeah, I didn't see anything that needed to be.
Okay. We can continue.
And then the next thing we'll do is finish up the last part of the PowerPoint presentation and then review the TTTG.
Did you want to share your screen for that, Dr. Reese?
Yeah, I can do it.
Okay, let me stop presenting.
Okay. Should be right here. Let me know if you guys cannot see this.
I see it.
Make this smaller. So where we left off last time. Okay, so what I did was I inserted the slides in that were shared with me by all the work group members to add in. So I marked them here because otherwise I would not remember. These 2, 3, 4 slides were new slides explaining how LVADs work. So we had this slide that we had edited and simplified, and then in here we have 3 slides that are new, supporting the left side of the heart, who gets these devices. I don't know if we want to be specific about the the 3 different LVADs that BUMCP cares for versus if we just want to take all this out. I'm going to leave it a little bit more vague, probably.
I would vote for vague, just I don't think the brand name is going to be helpful for people. That would be my thought.
Yeah, I don't think so either. And then how it works, it kind of talks about how it flows through the device, that it doesn't take over all the work, the heart still beats. And there's external power on the drive line. So meaning that they always have to be on external power. And then these are the different components. So this is just a picture. And then looks like there were 2 that were similar in terms of the different components. I don't know if we just want to keep one of these in. Because they're kind of the same slide duplicated. Pump, driveline, controller, and external power. Does anyone have a preference which one to keep? This one looks a little more simple to me, but.
Yeah, I just showed the other one. I was just looking at the close-up picture that just kind of shows at the top right, but I don't know if that's just device specific.
Yeah, because this is the HeartMate 2, and then this is the HeartMate 3.
And the other one's a different one, I think.
And I think the other one must be the other one. But they all have the same parts to them.
Mm-hmm. I agree. This one is necessary.
Maybe take out this guy. And then we'll leave this one. And so those were the different components. And then there was a slide for patient assessment that I stuck in. We had, I think, this one. And then this was the updated one that I was sent. Head to toe assessment, ensure the pump is on. And so this is how you tell the pump is on. And then the one we had said, I don't know, kind of the same thing. I don't know.
I think
kind of like the first one because it's very simple.
Yeah.
You know, it tells you exactly what you need to know. Just, you know, from a pre-hospital aspect.
Mm-hmm.
Yeah, I agree. And I think our old version, it's kind of irrelevant that they have a defibrillator as well.
Yeah.
So I agree. The new slide looks better.
Okay, I'll take that one out. And then we had this slide in patient assessment before, just talking about the different vital signs and how they're different. And then this was the new slide that I was sent. But again, it has like the Doppler or art line reference, which we don't have. This one includes the ECG tracing. It just has a little more information on it than the other slide.
Yeah, I do like the additional information, but I think the Doppler, my vote would be to just delete that because it's just not available in the pre-hospital setting. And then we probably need to spell out PPM and ICD just under ECG.
Oops. PPM.
Was that permanent pacemaker? I've not used. I'm guessing, but I don't know. That's not an abbreviation I've seen.
Maybe. I'll just say pacemaker.
And then the map, I think, is a questionable thing because I know a lot of EMS, even though they were taught that, I don't think they routinely use that.
Not really. We can delete that. I mean, we could just say, if we're going to use this, we can.
Isn't there a map guide in the CCCG?
Probably.
We do reference a map. It's just that I think, I mean, don't most of the cardiac monitors in parentheses give a map?
Yeah,
I feel like
The automatic ones do, but we were saying in this other slide that the automatic readings are not reliable.
Got it. Okay. Good point. So maybe under blood pressure, just say it should be taken with a manual cuff, because I think we don't, that would be the one piece we don't have. And then I think specifying that automatic blood pressure is unreliable.
What is this? May have SBP? May have a systolic.
Systolic blood pressure for that one.
May have systolic blood pressure if hypertensive or fluid overloaded. What does that mean exactly?
I think
Or is it peritonitis?
Sometimes if they have a pulse, you might get an automatic blood pressure cuff that works if they had a palpable pulse and their aortic valve was opening every beat. But that's hard to determine out in the field pre-hospital.
We'll get rid of that maybe. And this one maybe. There it is. And then get rid of this one.
I think so. I think it's. The only thing for the red background, I don't know if anyone else, it might just need to be a little bit bigger, but I'm just wondering if the red is hard sometimes for people to read, like a different color.
Oh yeah, we can make it like. Yeah, something like that.
Mm-hmm.
Okay. And then our next one, we have talked about bleeding complications, dysrhythmias, stroke assessments. And we talked about heart failure, falls and trauma, equipment failure being very rare, the critical connections, care of the driveline, look at the alarms. I think we took out most of these slides and just left this one simple one that showed the silence button. And this is the one we were talking about deleting potentially in lieu of this more simplified one. So this was the more simplified version I was sent. So there's one for LVADs and then there's one for the total artificial hearts that are down a little bit further. But this one, sort of this gets simplified to this, which is either the pump is running, so the lights are on, the pump is running. So yes, identify medical causes, follow ACLS, ensure adequate perfusion. I guess I'm not sure what that means. And supportive treatments. Like this is the part where it's just not very explicit what you're supposed to do. And then this one, if it's not running, call a code, which they're not going to do, obviously. Someone get the pump running, ACLS guidelines. CPR indicated if the pump is off and they're not diffusing, defibrillation, okay. So this one probably, yeah, I think we have to take this stuff out. But then this part, I wasn't sure. So LVAD emergency response. Go ahead, Gail.
I'm just wondering, like for the, on the green column, ensure adequate perfusion. I mean, I think it's trying to say administer IV fluids as indicated, and maybe that's, so if someone seems like they're not perfusing, administer IV fluids.
I mean, some of it would be, I mean, when we're talking, and I've dealt with a lot of emergencies over the years as the coordinator, usually we're talking to either the family or the paramedics on what the flow is on the LVAD off the actual controller itself. And trying to determine, you know, do we give IV fluids, or is this someone that's in severe right-sided heart failure where we don't want to give fluids, and we'd be more inotropes and, you know, epinephrine or dopamine. So we're looking at really the VADs running on that patient and what the flows are in liters per minute, because you're not going to be able to get a blood pressure for us out in the field.
Is there like a cutoff flow number?
I mean, it depends on the patient size and which patient it is, but most of them will alarm if they get closer to 2.5 liters per minute, depending how they're set. So, I mean, if they're getting low flow alarms on any of the devices, then it's trying to determine, I mean, if they're in severe right-sided failure and we're talking to the paramedics, they've got JVD up to their earlobes. If we give them fluids, they're going to end up being intubated. So, I mean, fluids aren't always the right answer for this patient population.
So should we say call the VAD coordinator to determine if fluids or pressors are indicated?
Probably. I mean, usually we're on the phone. Usually the family's calling the coordinator and 911 kind of at the same time. I mean, and we're working directly with the paramedics. I mean, we had an emergency in Sedona about a month ago, and we were talking with the paramedics on Cathedral Rock dealing with a bad patient in an emergency. And they were, you know, updating and telling us where we were at, and we managed the patient with them.
Yeah, so but saying here, follow ACLS, that almost tells me like chest compressions. That's how that could be read.
And you would never want to do chest compressions if the pump's running. So that's the green side where the pump's running. You would never do chest compressions on that side. So you might want to take the follow ACLS out over there. That's more the red side if the pump is off.
So but, go ahead, Gail.
So kind of when I look at, so for EMS, they're not going to be able to identify medical cause. We don't want them to follow ACLS. So I think that all those treatment algorithms we need to delete and probably just say call coordinator.
Yeah, you're really, I mean, you really want to get the coordinator on that side. It's going to be important. Because the pump is running. It's really going to be determining what's, it's either going to be pressors or fluid typically, or arrhythmia management.
Can we put arrhythmia treatment in here or defibrillation?
Possibly defibrillation. I mean, we had someone in VFib that was awake and talking, but they were in VFib and got transported in. They were awake and talking, and they had 4 liters of flow on their LVAD, so they would have been on that green side.
So is there anything else we would put in this green box that EMS would be expected to do? I mean, the only things I can think of would be defibrillation or arrhythmia management.
Right, that's the only, I mean, that's another big one is the arrhythmias.
And I think the problem is like, it's a little confusing. I kind of look at the EMS provider in the field. If we're saying, okay, look at the patient, if they're awake and talking and they're in VFib, they're going to go, is that like a pardon?
To let you shock them.
Exactly. So that's kind of like my question is, if you're saying this person was awake in VFib,
They were.
I don't think EMS, you know what I mean? We try to tell EMS to treat the patient. So I think that would be my only concern, would be putting that in there. It's a little confusing.
Mhm.
Yeah, I mean, but really for this, we're talking about like an unconscious, unresponsive person, right?
Yeah, the red side's the more critical side than the green side. The green side, you're going to transport them to the VAD center, and it's just determining, you know, which center you're going to get them to.
Yeah.
But a lot of these patients, I mean, this is a statewide training. So if they're up in many parts of Arizona, they're not going to transport to a VAD center because of the distance.
Sedona did. So we had our patient have a stroke on top of Cathedral Rock. One helicopter got him off the mountain, and the second helicopter transported him to St. Joe's. They
Yeah.
didn't stop at the nearest hospital. We said they needed to be at the nearest stroke center. And it was a good thing because he ended up having 100% occlusive stroke that required an intervention. And it helped him not being delayed 4 hours somewhere else.
Yeah.
Yeah, but I'm just saying that,
Severe.
yeah, we can't always rely on helicopters being available though, because there's many times of the year. So I just think we have to be cautious of like assuming that they're all, ideally, yes, but because this is a statewide curriculum,
Right.
I just want to make sure we don't
It's
give people
really
the,
working with the coordinator at the time and with the EMS and the medical director, you know, to facilitate getting them hopefully to the nearest VAD center if possible.
Mm-hmm. I mean, would we say defibrillation if needed, you know, depending on clinical condition or something like that?
I mean, you could if they're, if they were symptomatic, I mean, it'd just be tricky to sedate them. I mean, they, you know, if their flow was adequate on the device and they were talking to you, it's getting to the center we defibrillated the patient here. And they were in VFib for 18 hours.
Okay.
This is Sandy. I'm kind of thinking that what you put there, because they will be talking to the coordinator at that time. So if the coordinator feels that, you know, defibrillation would be needed, they would probably suggest that at that point, I would think. Does that make sense?
Mm-hmm.
Can anyone hear me?
Mm-hmm. Yes.
Yeah.
Okay. For some reason, my audio wasn't working. Sorry. Yeah, shouldn't we, in the green column, yes, shouldn't we be advising don't initiate chest compressions?
Because the pump is running, I wouldn't do chest compressions on that. On the
Yeah.
green side, long as the pump is running, you would never do chest compressions.
Hi, Linda.
Hey, Jeff.
Make it bigger. Okay. Was this good for the slide?
and just so I have a good understanding on the red column, we're assuming the pump's not running, the person's unconscious. So we'd want to, I think regardless, we'd be starting chest compressions, right?
Yeah.
Or are we saying that this is a possibility that the person would be conscious
They
with the
could
pump
be
not running?
conscious initially if the pump was off.
I mean, we're talking about, like my understanding is we're talking about like purely unconscious, like unresponsive people here. Right? In general?
I mean, they could be a patient that the pump is off, but they could be awake, Jeff, too, right?
Okay. Okay.
I just want to make sure that someone goes to pick up this training who's not part of this conversation, that it's really clear that they understand like how the patient may present. Just because for me, I'm kind of sitting trying to like picture in my mind, is the pump not running? They're going to call 911. By the time EMS gets there, which best case scenario is 6 to 8 minutes, best case scenario, without a pump running, how do we anticipate finding the patient? Because we're telling them that it's hard to determine if they're perfusing, like pulse is inaccurate, blood pressure is inaccurate. So they're going to go on, you know what I mean? So I'm just, the if not perfusing part, I think is going to be confusing for EMS.
You can say if unconscious and unresponsive.
I think so. And like I said, you know, as an emergency physician, we luckily don't take care of a lot of these patients. So I'd be calling you as well if I saw this person. So I just want to make sure that anyone who's picking this up is able to really teach this well. Does that make sense in terms of how the patient may present? That's kind of a question for you guys as the coordinators.
I think that makes it more clear.
Okay. Yeah, I think it looks pretty clear.
So you can get rid of that slide above it.
Oh yeah, you're gonna get rid of this. Right?
Yeah.
And then this one, so this is where we ended our review the last time. It was on the total artificial heart. So what we have here is VAD versus total artificial heart. I don't know if this is helpful.
Can you make the slides a little bit bigger, Amber?
Yeah.
Thanks.
I forgot it's not full screen for you. Big for me.
I think I like the comparison, if all of this is still accurate as summarized. I think it's a nice comparison, but I just want to make sure that that it's all accurate.
Yeah, I think it's all pretty good, useful information.
Okay. And then below that, we have the same thing for total artificial hearts. So again, we'll take that out to make it the same. What are they doing CLS if they don't do CPR correlation?
I don't know if on the green side you'd want the ACLS on that side. I would definitely put the no CPR, but the pump is running, so you wouldn't, I mean, you'd never do CPR with that device.
Trying to think of what other ACLS treatments you would give. I don't think there would be any.
Yeah,
They
there's no EKG.
Just airway support, rescue breathing. Yeah.
That's about it for that device.
Should we just use the same terminology that we had in the other one? Because I think it basically, essentially it's the same, right? Because we're going to call to determine if you're going to do all these. And again, I think the don't initiate chest compression is just again.
Right.
So essentially that for the green, if it's working, it would be the same treatment if I'm understanding that correctly.
It's just you don't have arrhythmias. There's a lot, I mean, being that you don't have an EKG, there's just a lot of things missing with the artificial heart patient that you don't have to treat. No tachyrhythms, no bradyrhythms. I mean,
Right.
you don't have.
Right, but we're still saying the same thing, the coordinator, to see if there's anything that's indicated.
Yeah.
We don't have airway management listed here. Did we want to put airway management as needed in these?
I would. I think that's a good point that Jeff mentioned, that, you know, we do want to specify that we still want to do airway management. So I think making sure, yes, call the coordinator, but in the interim, at least do airway management.
Okay. And then same thing over here. Call the coordinator.
If the TAH is off, they're going to be dead.
Yeah. So just call coordinator,
Yeah,
right?
pretty much call coordinator and change the driver. That's the only options you have. There's nothing else.
You want to say he cannot survive this, or?
So
Well, unless EMS is right on site when it happens, it's going to be too late.
so if someone, and so I think the two scenarios, one, they get there, the pump's not running. Do they just call the patient? You know what I mean? And that would be question number one. Number two, if they get there, the patient's talking to them and then the pump stops running, what could they do?
Change the driver.
How would they change a driver? How would they change the driver?
I mean, the Freedom driver, they've got the backup. Hopefully the family is with them because they should be with them at all times. But I mean, they have to turn on the driver and then switch the lines over.
Could you have the family change the driver?
I didn't hear that. I'm sorry.
Like, would you just say in here to EMS to tell the family to change the driver? Or, I mean, is there anything they would do?
Well, they should have done it already.
Yeah,
before.
they would have done it before you got there.
Okay. So call coordinator, that's it, right?
Yeah.
Okay. I just didn't know if we should, as an educational point, say something in here about the patient cannot survive failure of a total artificial heart.
I don't know, what are your thoughts, Jeff, on that? I mean, that's an event they're not going to survive if it's off for any
Yeah,
time.
you have probably 2 minutes tops to get the driver. Any EMS isn't going to be there in that window. So either the family did it already or it's futile.
Okay. All right.
And so then so the next step, if I was an EMS provider, I'd say, okay, there's nothing I can do. So do I still need to do my normal, like 4 rounds of resuscitation to call the patient? Because in order to do determination of resuscitation, so I'm just trying to like figure out if I was the paramedic responding, the total heart's failed. We've missed that too. So they're going to get there ideally 6 to 8 minutes. Typically to terminate resuscitation, they would do 4 rounds of MICR.
But you couldn't, no chemical's going to make plastic squeeze.
There's nothing to do. Yeah.
But, and I understand that, but they also are they can't just look at a body and say, okay, we're done. So they have to follow certain guidelines to do.
To say, we would have to have them call the base hospital then at that point to request
termination resuscitation.
Yeah.
Yeah. So I just want to make sure, like, because I think that's going to be a very gray zone, a confusing gray zone for EMS. Like, and really, MICR is not about the drugs; it's about compressions. So that's really the, you know, in their mind, they're like, we have to do 4 rounds of 200 compressions to call a patient.
I would take out the of resuscitation just primarily because they're not going to be doing it. Just call-based hospital for termination because they're not
Oh, yeah.
going to start resuscitation, are they?
Right. 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 And we can put in the notes like,
Can you go back a slide, the comparison slide, please? I just want to make sure they know how to determine that I just want to make sure they know that the TH is pneumatic. They're going to hear it, a pumping sound, because we're telling them to assess if is the pump running or not.
says right here, a galloping sound. It's
Okay,
audible
good.
without making a galloping type of sound.
Good. Okay. I just wanted to make sure that was covered.
And Amber, I like that note in that that you put in. I'm wondering if we should just put like a big star.
We get more outside of, like you're saying. Is that what you're saying?
Or even just like call-based hospital for termination and asterisk C notes, just to make sure that it'd be too much to fit in there, but I think that's a really good teaching point just to explain that this would not be your normal code that you're terminating resuscitation on.
Yeah, I mean, I could move all this up and just put something below it, potentially. Like another text box below.
Yeah, that might be good, just because I think it's just such a good like educational point. And I'm very thankful you're the one doing all this live editing because I'm impressed.
Something like that. Okay. Okay. And these are other slides, so I don't think that we need to probably keep these. And that would be the end of it then. Is there anything that we are missing? I think we got it all. Looks pretty good. And then the other thing that we have is the TTTG. So let's just make sure. Let's see if I can open it with Google Docs.
Do you want me to open a PowerPoint copy?
No, I think I got.
And so just so the group kind of knows the background on this piece, we had the old version in there and we got a request from an agency to update this because they pointed out that it was kind of limited only to VAD patients, didn't have anything regarding total artificial hearts. And so we're not actually due to update this, but if we feel like it is inaccurate, we definitely would want to update it now
Right.
and kind of potentially get it added to the agenda.
Yeah, Shelley, could you open the PowerPoint version? Mine doesn't seem to open on my computer. Thank you.
No problem.
So this one we would need to change if there was something that was specifically inaccurate, obviously.
Just from a layperson's perspective, maybe move the coordinator stuff up to under universal care, but that's a minor edit.
And I think Phoenix Children's, if I recall, do we need to add them too?
I didn't know that they were needing to be listed as a VAD center.
I think so. I think when this got adapted regionally, let me double check.
I think you're right, Dr. Bradley.
Yes, there is a PCH VAD number. I can give you that.
Go ahead.
602-933-8800.
All right.
And then just for consistency, just say VAD.
Okay.
And is the verbiage regarding CPR still accurate that we have here?
Yes, it looks like it.
Okay.
I'll move it up.
Maybe not the part that says follow appropriate cardiovascular condition specific protocol. I don't know. I think that's a little confusing. What do you think, Gail?
I don't like the bullet.
Follow appropriate cardiovascular condition specific protocols as indicated. I don't even know which ones that would include.
I would strike that and the bullet above it. Because they'd only be changing a system controller under advisement from the VAD coordinator.
All right, deleting that bullet.
Is this based on that algorithm now to add the total artificial heart, or do we need to do a completely separate page for that?
I would do a separate page. it'd be too confusing to add it into this one, in my opinion.
That's kind of what I was thinking out for the field.
Mhm.
Sorry, I lost my internet.
Not a problem.
Where are we at, Shelley?
The bottom of the page.
And we're comfortable with the fluid bolus as written because we're assuming that we've contacted the coordinator ahead of time. Is that correct? So under the AMT section where we have the hypoperfusing.
I mean, that should be fine. I mean, 300 mLs per kilogram isn't that much fluid. It should be okay.
Thank you. I just want to confirm that. And then I think we need to add, do a new one for total artificial heart then. Maybe can we just copy this one? And then we'll just change it live if that's not too hard.
What?
Shelley's cursing me right now, understandably.
Oh. I'll do my best.
Should we include adult and pediatric? I don't know. Are there any pediatric ones? Does anyone know?
They have implanted them at Phoenix Children's artificial heart.
You said they have or have not, sorry.
They have, yes.
They have, okay, thank you.
All right. Accepting suggestion.
You may want to have under includes where it has they had total artificial heart implanted. You might want to have a statement that their native heart, or at least the native ventricles, are removed.
May have ventricles removed.
They definitely do. I mean, it's a hard plastic pump that replaces the heart. It's a replacement pump, which makes it
You
different.
could just say patients no longer have native heart.
Right. Just because that's why we don't do the chest compressions and I don't have an EKG.
Natural heart. Native heart. Natural heart.
Native.
Native.
And this one.
So they definitely have a blood pressure.
Mm-hmm.
And they can use auto cuffs. But they can still assess for perfusion issues, I guess.
Mm-hmm. You can get rid of the Doppler part. all the way to a map. So,
I'll be your token person.
yeah, there you go. To assess patient percent hyperperfusion. So these patients will have a pulse,
Correct.
so you can just delete that line.
All right.
You can just put there's no heart rhythm, so no EKG in a separate bullet, or you can put it up in the include section.
Or you can say patient will have a pulse, but no EKG, or something like that.
Yeah, no electrical activity.
Pulse, but no electrical
It's-
activity on
No
EKG.
electrical.
Yeah, and no electrical activity on EKG. You get,
And pulse ox should work.
yeah, so you can delete that one.
All right.
Mm,
Is it a TAA program?
yeah. So you say never perform CPR on a total artificial heart at the bottom.
Yep, that's safe to say.
And then the rest of that can all get deleted, Shelley.
All right.
And then instead of a mechanical hum, what did we call it in the training?
Was it galloping?
How did you describe it, Jeff? You said something else too.
I don't know how to.
Can you make the sound for us, please?
It's more like thumping than galloping to me, but
Audible noise. Maybe thumping sound instead of noise, Shelley.
you could, I guess, say a pneumatic thumping sound. I don't know if that's more helpful or not, but
Maybe. And that's not even an exploitation, right? That's audible, right?
yeah,
You can even say it's audible instead of auscultation.
yeah.
It's
Could
just
be.
such a distinct sound because they've got 4 mechanical valves that you're listening to. I mean, you could hear it without a stethoscope.
Yeah. So pneumatic thumping sound should be audible.
Okay.
Should be audible, and then delete the rest. And are we calling them VAD trained companions? Is that what they're called?
You could just change VAD to TAH. That's fine.
So should we get rid of nearest appropriate facility? Because we're saying that the preference is the nearest to each facility. Oh, no, we're saying in order of preference. It sounds like, as I'm reading it again. Okay.
Yeah, because I don't think there's an appropriate facility. Nearest appropriate facility would be the heart facility, right?
Right.
Yeah, I don't think any other center would accept them.
Yeah, it looks just like here, it looks like they're listing these in order of preference.
Yeah, I would keep it as is because, you know, if they're somewhere far away from the TH center, the VAD coordinator may advise transporting to a local hospital in Kingman or wherever. I don't know. So that looks fine.
Okay.
They're going to end up at the TH center, but.
And then these patients do get nitroglycerin, correct? So can we delete that line?
Yeah, delete that.
And then get rid of the acquired 12 lead and cardiac monitor.
All right.
They're not gonna do anything on the monitor. And their baseline will not be arrhythmia. So just get rid of that whole line because they're not going to get any arrhythmias.
Oh, entire line. Okay.
Yeah.
Do we want to maybe specify that nitroglycerin is okay only because I think we don't normally say that like differently, but I think just because we say it's not allowed in bad patients, maybe saying nitroglycerin, after nitroglycerin is okay. I think just that comparison between the two groups.
Yeah, maybe okay to administer.
Maybe administered after consultation with TAH coordinator.
Yeah.
What's that? Coordinator?
One thing we may want to add, and that we didn't have on the LVAD one as well, is to bring the patient's backup equipment.
Oh, under, yeah. And put that into that one as well.
Yeah.
I'll fix that bullet.
Okay.
After we get off.
And what do we have this one titled, Shelley, the first one?
On the total artificial heart page.
Yeah, what about the other one?
Do we need et cetera?
Yeah, I was going to say, it seems like there's, I think these are just LVADs, right?
Yeah, I don't know of anyone doing BiVADs or RVADs that are discharged out of the hospital.
If we could
So
just that, maybe? Oh, yeah, that's probably fine. I just wanted to take out the et cetera because we split off artificial hearts.
All right. Any areas you'd like to view again?
Do we want to put in the inclusion criteria something about this does not include total artificial hearts? Please see total artificial heart.
I think we have excludes, I think so that would be like a new excludes and then it would refer to.
Yeah.
I'm looking at.
Yeah.
And then I think we typically, Shelley, have a link to the like excludes total official hearts, comma, refer to, and then the hyperlink to the total artificial heart guideline.
Okay.
XXX works for now. So my hope, because I do think that these are some important edits, we are not up to update the TTTGs at a statewide level probably for another year. But I think that these are things we could potentially update now and get into the statewide guidance. So if you guys are comfortable with these, the next MDC is 2 weeks from tomorrow. Shelley, I think we could put these on the agenda, correct?
Yeah, if you like. Making a note. Add VAD and artificial heart to MDC agenda. I'll give you the VAD centers an invite to the meeting link, and if you'd like to attend or give input.
Thank you for providing these updates. I think this is really good improvement to the presentation, and it's definitely adding in the total artificial heart guidelines, a great addition as well. So thank you.
Yes, thank you, VAD centers participants.
And big thank you to Amber for all the legwork on this.
Oh, no, it was nothing at all. Cool. All right. Well, if that's it,
All right.
adjourn. Thank you all for your help.
Thank you.
Very welcome.
All right, thank you, everybody.
Have a good
Bye.